Good day, everyone. Thank you very much for joining the Center for Global Surgery at the McGill University Health Center webinar on the Trauma and Disaster Team Response course. I'd like to thank a few people just to start, and we are working through some technicalities, so more will be joining shortly. First of all, the work that you're going to be seeing here presented has been supported by the Royal College of Surgeons and Physicians of Canada, and we would like to thank them for all the generous support, and also like to thank the teams all over the world that have been incredibly impactful in serving their communities, not just through trauma care, but really in dedication for comprehensive, improved healthcare to their communities. Today, we will be hearing from a few of those teams, specifically in Senegal, in Nepal, and in Palestine. And of course, we will be hearing from Jeff Ibbotson and Cindy Moyes from Global Surgery Foundation. We've been incredibly privileged to have these partners as we work to overcome some of the gaps in trauma care and access to trauma care around the world. And they truly are, all our partners are incredible leaders and have spearheaded this incredible project. I would also like to thank our team here, specifically Gabriela Sanchez, Stephen DeMarco, Stephanie Toigo, with whom this work would not have been possible. And of course, as you all know, Dr. Jeremy Grushka, who runs the Center for Global Surgery we do that together, and you'll be hearing more from him. So we have a packed hour, so we'd like to start.
Namaste and good morning, everyone. I am Dr. Samjana Bosnith from Nepal, and I am an associate professor at Kathmandu University School of Medical Sciences, Dhulikhela Hospital. Today, I'll present on TDTR, Disaster Response and Capacity Building. Dhulikhela Hospital is a major referral center serving rural and semi-urban populations and plays a key role in emergency and disaster care. It has been actively involved in strengthening trauma care system and disaster preparedness in a resource-limited setting. Now, I'll briefly introduce Nepal and Dhulikhela Hospital with its outreach centers network. At first, I will highlight the disaster context in our catchment areas. Then, I'll present the TDTR course and our capacity building efforts. Finally, I will impact of our collaboration with the Center for Global Surgery. Nepal, officially the Federal Democratic Republic of Nepal, is a landlocked country in South Asia, bordered by India and China. It is highly prone to disasters such as earthquakes and landslides due to its geography. The country is divided into the Terai, hills, and mountains, with about 2/3 being hilly and mountainous terrain. This challenging geography limits access to healthcare and significantly affects emergency response and trauma outcome. Dhulikhela Hospital, affiliated with Kathmandu University, serves as a bridge between rural communities and tertiary level care. It is one of the Nepal's leading community-based hospitals. It provides services to around 2.5 million people and also receives patients from more than 50 districts nationwide. The hospital has a network of 21 outreach centers and 1 outreach hospital, serving over 50,000 patients each year. Nepal is highly vulnerable to natural disasters due to its complex geography and location on active tectonic plates. Globally, it ranks 4th in climate change vulnerability, 11th for earthquakes, and 30th for floods. Overall, Nepal is among the top 20 multi-hazard prone countries in the world. Earthquake has severely affected Nepal over many years. One of the most devastating was the 1934 earthquake with the magnitude of 8.0, which caused around 10,000 deaths. More recently, in 2015, a 7.9 magnitude earthquake struck Nepal, resulting in over 9,300 deaths and affecting nearly 40,000 families. These events highlights the country's high vulnerability and the urgent need for strong disaster preparedness and response system. During and after the 2015 earthquake, we observed that many patients died before reaching tertiary care hospital. This is due to a number of reasons. Firstly, our first responder often lacked essential emergency care skills, and pre-hospital emergency medical services were underdeveloped. Rescue and referral transport were frequently delayed, especially in rural, as it is hard to reach areas. In addition, we have limited surgical capacity at peripheral centers, and the lack of standardized disaster triage further contributed to preventable deaths. These gaps highlights the urgent need for a structural training program to strengthen trauma and disaster response, especially in rural settings. The Senegal Hospital functions as a regional trauma referral hub, providing 24-hour trauma, acute and definitive care services. It also plays an important role in training and academic leadership, helping build capacity among healthcare professionals. In addition, the hospital is actively involved in strengthening integrated pre-hospital care and improving coordination between pre-hospital and in-hospital emergency services. We currently have more than 20 training instructors on TDTR. So far, we have trained over 100 participants from different disciplines, including surgery, general practice and emergency medicine, orthopedics, nurses, the paramedics, and the residents. The courses has shown strong impact with around 95 to 96% improvement in the participants' knowledge and skills. Beyond individual training, TDTR strengthens the health system and promotes a sustainable in-country educational model. TDTR emphasizes a structured approach to emergency and disaster response. It ensures rapid team mobilization and a coordinated response with a defined roles. Overall, TDTR enables team to function effectively under pressure and deliver timely life-saving care. These are the few glimpses of training sessions. Training was practical and context-specific. We did repeated training. We expanded pre-hospital level and integrated into hospital system. The course has enhances early recognition of critical injuries, faster airway and bleeding control, and efficient triage under pressure. It also strengthens safer transfer and referral systems. Overall, TDTR improves emergency response capacity and helps reduces mortality in trauma and disaster situations. We started our partnership in 2016 and have conducted multiple life-saving trainings programs, including Basic Life Support, BLS, Primary Trauma Course, Rural Trauma Development Course, TDTR in Sindhu Palchok and Kabri districts. These initiatives have strengthened essential life-saving skills among healthcare providers. They also supported development of Nepali BLS curriculum. This helps us in strengthen pre-hospital care and build a more organized and sustainable emergency care system in Nepal. Overall, the training has enhanced disaster readiness and improved systems' ability to respond to other type of emergencies or disaster event, such as flood or COVID-19 pandemic. This collaboration has improved staff confidence and better prepared healthcare providers in emergency and trauma care. We also have students from the Center for Global Surgery. Olivia worked on enhancing trauma care at Dhuli Khel Hospital through implementation of the EMBAR system. KEDAR focused on pre-hospital care in Kabra districts, assessing the current status. These activities have strengthened both clinical practice and system-level improvement in trauma and pre-hospital care. Overall, this has improved preparedness across all levels of care. It highlights that capacity building at every level is essential to strengthen trauma care, especially in resource-limited settings. Finally, I would like to sincerely thank the Center of Global Surgery, especially Dr. Dan, Dr. Jeremy, and the CGS family for giving me this opportunity. We look forward to more collaborative work in strengthening trauma care in future. Thank you very much for your attention. If you have any questions or queries, please feel free to ask. Thank you. Namaste.
Thank you very much, Samjana. Next, it's my pleasure to introduce our partners coming from Senegal in West Africa. We have Professor Ibrahim Konate and Professor Mustafa Zizou from the Albert Berger Hospital in Saint Louis, Senegal, who have been instrumental partners at really leading a national surge to augment capacity for trauma care and critical illness within Senegal, and have been leaders in establishing new formats for education and training and capacity building for trauma care, both in the hospital setting and newly within the pre-hospital setting. Ça fait un grand plaisir d'introduire nos partenaires du Sénégal. Thank you very much.
Bonjour à tous, je suis le professeur Mustafa Diegou, je suis médecin anesthésiste réanimateur, je suis diplômé en urgence sanitaire et en épidémiologie, et je suis diplômé aussi en Traumatism Disease Team Response, un diplôme délivré par l'Université de McGill à travers le Centre de chirurgie mondiale, à travers l'Université Gaston Berger où je suis enseignant-chercheur. En effet, l'origine de cette coopération, ça a été il y a 5 ou 6 ans derrière, avec vraiment une première étude sur les traumatismes. Cette première étude avait pour objectif d'évaluer le dispositif national du système préhospitalier. Et cette étude a montré qu'il y avait en réalité une disparité entre deux zones distinctes dans le pays, des zones où on avait un système préhospitalier mature, qui à l'époque était seulement au niveau de Dakar et de Saint-Louis, et un système préhospitalier immature où en réalité le préhospitalier, les soins préhospitaliers n'existaient pas. Et donc cette étude nous a permis de comprendre d'une part qu'il faut en réalité continuer le développement du système préhospitalier, mais aussi ça nous a permis de savoir que les sapeurs-pompiers étant les plus nombreux nécessitaient un accompagnement en termes de formation. Et donc nous avons aussi travaillé de façon collaborative pour voir dans nos données que les traumatismes représentaient en réalité plus de 40% de la mobilité dans les services d'urgence. Et donc, face à cela, nous avons accepté naturellement et de façon mutuelle de travailler avec l'Université de McGill pour commencer des séances de formation en traumatisme disease team response. Première étape. Nous avons mené tour à tour vraiment cette formation en TDTR qui a commencé à l'Université Gaston Berger de Saint-Louis. Et donc l'originalité de ces formations que je salue ici et que nous continuons à faire, c'est que c'est des formations en équipe qui se font en même temps avec tous les acteurs qui prennent en charge les traumas, les infirmiers, les médecins, les ambulanciers, les brancardiers, les chauffeurs. Tout le monde est formé de la même façon et on est tous formés pendant le même moment et ça permet vraiment d'améliorer la coordination. Et donc à Saint-Louis, c'est une très grande réussite parce qu'il y a des teams trauma qui sont mis en place. Les habitudes commencent à changer, l'organisation, la réflexion. J'adore citer Jérémy ou bien Dan qui dit que le patron, c'est vraiment la physiologie, l'état physiologique du malade. Et c'est cet état physiologique qui nous permet en réalité de prendre des décisions. Et ça, c'est vraiment quelque chose de génial. Il y a énormément de choses dans la physiologie et dans la philosophie de la prise en charge du trauma qui nous a été enseignée et que nous essayons de répertorier et d'enseigner à notre tour à la jeune génération. Et donc, deuxième chose, c'est que je vous avais parlé de la première étude qui, en réalité, a montré qu'il y avait surtout un système préhospitalier majoritairement dominé par les sapeurs-pompiers. Et donc, il fallait les former. Et nous avons initié à Saint-Louis plusieurs séances de formation auprès des pompiers et ensuite à Dakar. Et ça a vraiment fait un impact énorme, notamment dans des techniques simples, par exemple d'immobilisation, de contrôle de l'hémorragie, de gestion des voies aériennes. Et tout ça nous a permis, en réalité, d'améliorer légèrement la prise en charge, même s'il faut la mettre à l'échelle. Et donc, cette partie représentait la mise en œuvre de tout le projet. Alors, quel est l'impact? L'impact, nous l'avons vu notamment à Saint-Louis, à travers beaucoup d'études qui sont réalisées après avoir initié les formations de TDTR, où vraiment le challenge, en tout cas, c'est de ne pas avoir de mortalité pour les traumas ou de réduire la mortalité. Alors, l'impact va se voir sans doute dans des études ou dans des thèses que nous ferons au niveau de la zone de Saint-Louis et que nous aurons le plaisir de partager avec le Centre de chirurgie mondiale pour évaluer en réalité le pronostic en termes de complications, en termes de mortalité associée à ces pathologies traumatiques. Et nous sommes certains que ce sera en réalité une mortalité qui sera en baisse. Quel est l'impact? Au niveau du préhospitalier, on espère en tout cas un impact qui vraiment va favoriser une meilleure coordination des urgences avec un travail, une standardisation des procédures et des pratiques entre nous, médecins, et les sapeurs-pompiers, d'autant plus que nous travaillons dans la même zone, ça veut dire la zone préhospitalière. Et donc ça c'est à saluer, nous sommes très contents là-dessus. Et en termes de perspective, Dieu fait bien les choses. Actuellement, je suis le directeur du SAMU national du Sénégal. Après nous avoir raconté toute cette histoire en rapport avec le travail qu'on a mené dans le préhospitalier, Dieu fait bien les choses. Nous sommes dans une institution qui s'occupe en réalité des urgences préhospitalières. Alors en termes de perspective, nous envisageons et vraiment émettons le souhait de continuer à collaborer avec le Centre de chirurgie mondiale de McGill, avec l'Université de McGill qui est à Montréal, collaboration qui va nous permettre en réalité de mettre en œuvre justement toutes ces mesures de bonne pratique dans la nouvelle institution que nous occupons, en l'occurrence le SAMU national, mais aussi ça nous permettra de déployer ces formations, cette coopération au niveau national, au niveau de tout le territoire sénégalais. Je vous remercie énormément de votre attention et vous avez vraiment, je vous transmets toute notre salutation à toute l'équipe du Centre de chirurgie mondiale de McGill. Merci, thank you.
C'est un plaisir pour moi de parler de ce partenariat très intéressant entre le Centre de chirurgie mondiale et notre unité de formation et de recherche de l'Université Gaston Berger, que nous avons démarré en 2019 avec la signature d'une convention. Il s'agit d'un partenariat qui est très équilibré parce que l'Université de McGill apporte avec lui, particulièrement le Centre de chirurgie mondiale, apporte avec lui son expertise dans la traumatologie et dans la recherche. Et nous, avec la connaissance de notre milieu que nous voulons également transformer par la réduction donc, de tout ce qui est mortalité chirurgicale, spécialement pour ce qui est de la traumatologie. Donc, au cours de ces années, nous avons fait plusieurs activités où il y a eu une bonne communication entre nos différentes équipes et la participation donc, de cette équipe de chirurgie mondiale, particulièrement le docteur Dan Eckelbaum, Jérémy Gouchka et Tarek, qui ont participé activement aux enseignements du programme de résidence des chirurgiens que nous avons mis en place quelques années avant. Et cette aide a été très précieuse, d'autant plus qu'il y a des cours spécialisés qui ont pu être développés. Et parallèlement à cela, le Centre de chirurgie mondiale a participé à la formation de TDTR au niveau de Saint-Louis, mais aussi de Dakar, de toutes les régions du Sénégal, où il y a eu la formation des instructeurs qui ont été formés pour autonomiser un peu le centre. Et ça a été très bénéfique dans le cadre de cette expertise, de transfert d'expertise de la prise en charge traumatologique, qui a permis à nos équipes d'acquérir des réflexes dans le travail en équipe et de pouvoir bénéficier de la de l'expertise du Centre de chirurgie mondiale. Nous avons également développé un volet dans la recherche où plusieurs articles ont été faits. Notamment, nous avons travaillé dans un article de recherche sur la traumatologie, sur le système préhospitalier sénégalais, qui avait montré que les sapeurs-pompiers étaient en avant et ils étaient présents partout au niveau du Sénégal. Et cela a permis aujourd'hui de mettre en place un grand programme qui est le programme de formation du personnel de santé, mais aussi qui inclut les sapeurs-pompiers et qui est aujourd'hui dirigé par le professeur Moustapha Diédiou, qui a été nommé récemment le directeur du SAMU national, ce qui permet donc de plus cette expertise de le transposer au niveau national pour qu'on puisse avoir plus tard la mise en place du registrement également pour lequel nous avons commencé à travailler avec le Centre de chirurgie mondiale.
Delivering trauma care in Palestine is not only a clinical challenge, it is a constant test of preparedness within a fragmented health system operating under continuous pressure. In this context, building structured, team-based and trauma response is not optional, it is essential. Juzur for Health and Social Development is a Palestinian non-governmental organization established in 1996, working to strengthen health systems and community resilience through capacity building, public health programs, and emergency preparedness initiatives. Within this role, Juzur leads the implementation of the TDTR program in Palestine and is the only certified training center authorized to deliver this training. In partnership with the Center for Global Surgery at the Miguel University Health Center, Juzur launched the first TDTR courses in 2016 and has since served as a national platform for developing courses, faculty, and trainers. This represents a successful model to transfer of technology in trauma training with strong recognition across the Palestinian health sector. According to the Palestinian Ministry of Health 2024 data, the health system in the West Bank is operating under extreme pressure. The hospital network with 1,756 beds is functioning at a bed occupancy rate of over 93%. In several major hospitals, occupancy exceeds 100%, reaching up to 117% in facilities such as Beit Jala and Hebron. More than 1 million emergency visits and over 500,000 outpatient visits were recorded in a single year, reflecting the extremely high demand placed on the system. This level of utilization demonstrates that hospitals are consistently operating or beyond full capacity. These pressures are further intensified by structural barriers, including checkpoints, closures, gates, and the separation wall, which fragment referral pathways and delay access to care. In such context, structured trauma preparedness becomes essential for maintaining system functionality. Before TDTR, trauma care was characterized by variability in training and practice. There was limited standardization, weak coordination among teams, and the lack of simulation training based. These gaps affected the efficiency and quality of emergency response. Since 2016, TDTR has expanded across Palestine through structured training delivery. A total of 2 instructor courses and 12 provider courses have been conducted, training 266 healthcare providers from different disciplines. The program has reached physicians, nurses, and other healthcare cadre across North, Middle, and South districts, including East Jerusalem. It has been implemented across Ministry of Health facilities, UNRWA, private hospitals, and NGOs, ensuring system-wide coverage. A key achievement has been the development of strong local capacity. 15 national instructors are now actively engaged in delivering TDR training. Juzur leads implementation independently while maintaining coordination with international faculty and Miguel. This ensures sustainability and continuity despite movement and access constraints. This simulation demonstrates the practical application of TDTR principles in real-time trauma scenarios. It highlights structured patient assessment, clear role allocation, and effective team communication under pressure. Simulation-based training allows healthcare providers to safely practice high-risk situations and strengthen both clinical and non-technical skills. These competencies directly translate into improved performance during real emergencies. Our experience highlights several key lessons. Continuous training is essential in unstable environments to maintain readiness. Simulation is critical in strengthening real-life emergency response. Local ownership ensures sustainability, and multidisciplinary training improves coordination and patients' outcomes. Looking ahead, Jazur plans to expand TDTR to primary healthcare providers and introduce blended learning approaches. We are also exploring AI-supported simulation using real clinical scenarios. A key priority is the re-establishment of the Jazur Training Center in Gaza with full simulation capacity, along with development and certification of new TDTR instructors. These steps will further strengthen trauma preparedness and system resilience across Palestine. Thank you.
Hi, everyone. Greetings from Geneva, Switzerland. It's wonderful to be with you, and a big congratulations on the 15th anniversary of the Center for Global Surgery. I'm very pleased to be able to join you today and look forward to the question and answer period afterwards. For the Global Surgery Foundation, we are very pleased to be partnering with the CGS and McGill University. It's been a long-standing partnership right from the very beginning of our existence, and we really value our partnership together. I'd like to really focus in on what our partnership with CGS is doing, and that's focused on the Surge Hub. Surge Hub itself is a joint initiative of the Global Surgery Foundation and UNITAR in partnership with the Royal College of Surgeons of Ireland and supported by the J&J Foundation. And I'm sure most of you have already heard about it and used it, so I want to take a more broad, high-level approach to this presentation. We've got a huge deficit in surgical care professionals. And I don't mean just surgeons, but I mean the surgeons, the anesthesia, the nursing. And the training at this point is scattered. And it's, to be quite honest, if in the traditional methods, we'll never catch up. And so we need to start looking at other ways to provide the care, to provide the training. And so we really need to scale the workforce, and it needs to be done in such a way that it's accessible no matter where you are. So one of the solutions that we've come up with, which is very closely linked with the Center for Global Surgery at McGill, is the Surge Hub. And this is essentially a platform, a one-stop shop for all the surgical training that we can access and focused on resource-limited settings. And really, it's the first UN-backed training specific for surgical care. The features that are really quite unique and make this one of a kind is that it is United Nations based, being with UNITAR, which UNITAR has the mandate for training and research. We've developed the platform to be extremely user-friendly. So it's, you try it, you can be on registration and into a course within 60 seconds. It's so easy. For locations with bad internet penetration, you can download the courses and then work offline. The other interesting thing is the content providers, they maintain full ownership, copyright, intellectual property of the courses. We just serve to upgrade, get it online, and get it out to a broader audience. And so this is a real good example of true partnership. And then, of course, there's the community features. There's lots of opportunities to build community around the Surge Hub, and I'll get to that in a little moment here. We're very pleased to have, over the last couple of years, won 2 international education awards. One was the awards, and the other was the Reimagine Education Awards, which was just last year, and it's won first prize for the best online learning platform in the world. So we were quite pleased with this. Now, the really exciting thing, we started in mid-2023, so we're just, we're coming up just to our 3rd year, and we're already over 43,000 users in more than 200 countries and territories around the world. More than 19,000 certificates of completion have been handed out, and we have 135 courses already available, with many more in the pipeline being reviewed and getting ready to be uploaded. We're working with more than 32 partners and more being signed on. Even the last week, we've signed on a few more partners to provide content. And finally, one of the things that was sort of an unintended finding was that there's so many learners who are in fairly significant conflict areas, like the Ukraine, the Middle East, Sudan, all in all these hot spots. We have learners taking these courses, which is a real testimony to the applicability of the Surge Hub as a training mechanism. A little bit more of the information. You can see here the levels of training. Most of the people are actually working in practice or in their educational training. You can see that most are surgeons, and then the next cohort is nurses. And in fact, this is a little bit old data. I believe over the last few weeks, nurses have overtaken surgeons in terms of the number of people utilizing Surge Hub, which we're really happy about, because when you think about it, for one surgeon, there's probably 10 nurses, and we should have more nurses using. Let's talk a little bit about the Trauma and Disaster Team Response course. This course, out of the 135 courses, is right now, it goes between 2 and 4 of the most popular, most used courses on Surge Hub. Over the 3 years that we've had it up and running, we've had over 3,000 course enrollments with over 1,000 UN certificates awarded. And this is what I always get a kick out of seeing, is 7,157 hours of total study time, which it's 298 days of learning. It's incredible the amount of time, and it's wonderful to see. The course gets a very high rating at 4.6, and I think it's just one of our most successful courses on the Surge Hub. To give some of the information, UAE is actually the #1 spot it's being used, followed by Philippines, Nepal, and you can see the rest of the countries that are using it highly. In professions, nurse #1, almost double the specialist surgeons. So that's really great to see. And it's a very nice range of specialties within the surgical team that are taking advantage of this training. So what's coming? There's a new upgrade on its way. We're upgrading a lot of the courses and just making the pages more appealing and easy to navigate, more engaging. And so this new upgrade for the TDTR course is going to be going live soon. What I want to ask you now, I need your help. And we have a really ambitious goal. All the work on Surge Hub has been so exciting. What we would like to do is just get this out to more people. To be quite honest, if you look at how many people are out there that need good training available and access, it's probably hundreds of thousands, and yet we're only reaching now just over 40,000. So we've set a crazy ambitious goal by the World Health Assembly, which is in 1 month, to try to reach 50,000. That's 7,000 more to reach our goal. So the big goal is by the end of 2026, we want to reach 100,000. I challenge you, ask you, and really look forward to seeing a blip in the next couple of weeks as you go back and can share this with your colleagues. So thank you very much.
I would like to thank the presenters for really eye-opening discussion of some of the challenges that they have in their own contexts. And each of these really does present significant challenges. The work in Nepal has all been post earthquake, where the resources and healthcare infrastructure was really at baseline stage. The work with the Palestinians has obviously been done, much of it during an ongoing conflict, reflecting some of the most difficult environments to work in. And the work in Senegal really was looking at how do we support pre-hospital systems to improve better access to trauma care. I just want to transition it to Dr. Grushka, who's the co-director of the Center for Global Surgery, to help with the moderation of a discussion.
Thank you very much, Dan, and thank you again to all of our presenters and to everyone for joining here. Just as a reminder to all of the participants, please feel free to use either the chat prompt or the Q&A prompt, which you can see at the top of your screen, to enter any questions or comments that you would have for our presenters. I'll be happily monitoring that area and to help facilitate posing those questions. We're very pleased to have a number of our presenters with us here today for this call, and we thank them for participating. So for our partners from both Nepal, Senegal, as well as Palestine, if you can turn on your cameras and be present and join us for discussion. As has been mentioned by a number of our presenters today, this work is always possible because of leadership and collaboration and teamwork amongst participants in various different environments. It doesn't take much in order to bring this type of work to your own hospitals and to your communities, but it begins with local champions who recognize a need and desire, and it's from that these amazing programs can grow. First question which we have here in the chat is, what is the biggest challenges in increasing the scale and delivery of such training paradigms? So I turn that over now to Simjana, to Prof. Kanate, and to our partners from Palestine, or to Dr. Maye in Palestine. What were some of the hurdles that your group had to overcome in order to build up the training capacity for TDTR?
Everybody, or good morning in Canada, perhaps. I'm happy to participate with you today. Thank you very much for the meeting. Starting with, it's always a pleasure to thank the pioneers who started this project and who make the trauma easier in Palestine. Talking about the difficulties in the beginning, we do not have like the team spirit to work together because usually we are used to have training like every team alone, physicians alone, nurses alone. So the TDRT bring all the people together, which makes it great. And then we started to speak a common language. First of all, the difficulty that we have on ground, that unfortunately we have checkpoints. So as a team, and the instructors have to move from place to another. Like when we do the training in Jerusalem, we have just to take locals from Jerusalem and do the training in some place in Jerusalem. While doing it in Ramallah, also we had to shift to the West Bank and vice versa. So I think just gathering the people and the borders was a little bit difficult during this difficult time.
Thank you very much. Definitely always geopolitical realities can influence how we can bring in participants and trainers. I return again to you, Samjana. Have you been able to establish? Perfect.
Yeah, okay. Hello, everybody. Thank you for this time. And yes, we have many difficulties, but somehow we managed to do multiple TDTR courses. The first technical, maybe it's first issues for conducting training is managing logistics. If we can able to manage logistics, then we can easily do the multiple courses. We have many trained trainers. So I think from now it's good to go, and we can do ourselves also.
Thank you, Samjana. Fatim, you have your hand raised. Please go ahead.
So in order to overcome the movement restrictions, resources limitation, and system fragmentation, the most important factor was to build local capacity. Jazur developed national instructors and local faculty and ensured that TDR could be delivered continuously despite movement restrictions and limited access. And of course, the local ownership allowed Jazur to sustain the training and to adapt to the Palestinian context and to maintain preparedness over the time. Thank you.
Thank you very much. Another interesting question that was raised here in the chat. If you had to prioritize one intervention to strengthen trauma systems in low resource settings, what would it be? Professeur Konate, peut-être on va tourner vers vous et ça va me faire plaisir pour traduire votre réponse en anglais si vous êtes plus à l'aise pour répondre en français. La question, c'était s'il y avait une chose qui était la priorité numéro 1 pour augmenter la capacité des systèmes de trauma pour vous à Sénégal puis en Afrique de l'Ouest. Qu'est-ce que sera cette première priorité pour commencer à augmenter le système de trauma?
Okay, thank you very much. We are very happy to participate to this debate. I will try to speak in English. I'm not very good, but if Jeremy could precise if it is not very clear.
Aucun problème pour traduire.
Okay, I think there is no thing to prioritize. Everything is important to strengthen the trauma system. But what is very important is the human resources, strengthen the capacity of the human resources, because you don't need anymore, you don't need finance to do that. It's just a kind of willing. And to make this training, and the TDTR was very, very important to make the people work together for the same goal. Because in the same hospital, people are working differently. In the same countries, people are working differently. And if there is something to prioritize, I think it is the training, and also to make the policy, to convince the policymakers to build a better system of trauma, to make it a policy for the country. Thank you very much.
Thank you very much, Prof. Konate. Another interesting question and brought up into the chat is, how do trauma preparedness priorities differ, and if they do, between high income and low resource countries, and why? And perhaps to begin with, then we may turn that over to our partners over at the Global Surgery Foundation. Jeff, I know that you're online. Perhaps you'd like to take a stab at that question.
Yeah, hi, Jeremy. Hi, all. Great to be here. Jeremy, could you just reiterate the question again? Sorry.
Sure. Yeah, there was a general question wondering if there were actually differences in trauma preparedness between high resource or low resource areas, and if there were differences, what would those be, and how do we go about addressing them?
Well, as many of the people on the call will know, that in the really remote, resource-limited areas, a lot of the severe trauma simply don't make it to the hospital. And so oftentimes it's orthopedic in nature. So there's actually, if you actually speak about trauma in low resource countries, most people automatically equate that to orthopedic trauma. But there has been a significant shift over the last several years because pre-hospital transport's improving in various settings. And so the patients getting to the emergency departments and the trauma systems are sicker and sicker because they are surviving. And so there needs to be a scale up of those initial emergency traumatic injury procedures, that damage control work and so forth, because that experience is just very limited in the resource limited areas, because they simply don't have the infrastructure, the even the simple things like blood banks and different plasma products and so forth. So I think the overall system approach needs to be addressed, and that has to happen in conjunction with training of the staff. And I think the key element, which is so well featured in the McGill course, is that it's a team approach. One of the other speakers mentioned that oftentimes the nurses go and do their training, and then the surgeons go do their training. It's so important to do it all together. And this is, I think, a really key feature for the TDTR course. I think some of the features that are going to be more important for low resource settings is that pre-hospital transport, the referral pathways, the communications to prepare the receiving facilities, what's coming. And so with advent of technologies, I think this will be improved. And I think also mentorship. We have to support our colleagues who are in the more remote areas. And I've worked in Northern Canada, and the same problem is up there. Some of my colleagues in very remote areas of Northern Canada needed that mentorship and support from the tertiary, secondary trauma centers. So all of those elements play into it, but it's exciting to see the transition from what was the situation decades ago to now what it is today. Thank you.
Thanks, Jeff. I think that we're almost at the top of the hour, and that brings us to a very good place where we can begin to kind of take some take-home messages and wrap things up together. Before we do that, a hand that came up, which is always exciting. Please, Anwar Baroud, go ahead. The floor is yours.
Hello everybody. I'm Anwar Baroud from Palestine. I want first to thank McGill University, Dr. Dan, who I meet him many times, and Dr. Jeremy. It's an honor to participate in this webinar. Also, I want to thank Jazur Institute, which works hardly to spread and coordinate for such courses by Dr. Umayya Khamash, who is the president or the general director, and Mrs. Fatin. But I want to ask, how can we measure the influence and the impact of such courses practically? How does it affect the healthcare providers? I mean statistically.
I think that's an excellent question, one that is always brought up when we look at any other type of educational resource. And if there are any of our participants or any of our presenters who would like to answer, please go ahead and raise your hand. To kick that off at one part, I think the fundamental impact has already been evident by the presentations that we've heard today. Education takes two ways that it's going to impact care. One you could look at through surveys and retention of information, but the fundamental impact is that it galvanizes people, it brings them together, it educates them about a need, it excites them about an opportunity, and it creates a spirit of training and partnership. You start to build up your skills, and as you build up your skills, you slowly implement them into practice. And there's a difference between an epidemiologic impact and a clinical impact. And to share an anecdote from one of our courses in Senegal, when we were first working on our essential trauma skills course in Saint Louis, as we were training firefighters on essential life-saving principles in trauma. 2 weeks after doing that course, there was an unfortunate road traffic accident that resulted in an open femur fracture with significant hemorrhage. And for the first time, one of the firefighters who participated was able to place a tourniquet, stop the hemorrhage that was present, bring that patient to hospital with minimal blood loss, went to an operating room, fixed, their life was saved, their limb was saved. We can look at impact from the idea of a broad spectrum epidemiologic study, or we can try to assess that by a life saved. And I think the clinical reality that can show directly from a course to 2 weeks later a practical application and saving a life is a testament to the value of education. And the sheer fact when we see the number of people who on the Surge Hub platform are registering to take this course speaks, one, to the need. Secondly, that it continuously stays at that point shows that the information that's gathered is essential and practical. And then thirdly, when we hear the stories like have been shared by all of our participants, we see the impact that has on a clinical basis. So we can do pre-test and post-test studies and evaluate through online learning tests how information is retained. But I think when we hear these testimonials from patients and practitioners, it speaks to the value of the education itself. Jeff, I see you had raised your hand. Please go ahead.
Yeah, I was just going to echo what you said, Jeremy, but it really comes down to data. We need to start tracking our data. And some of the stuff that we're doing, if I am allowed, I could share a simple slide, which I think would hopefully really inspire people. And this is some of the data that has come out of some of the programming, which is using Surge Hub. Look at over here. Can you see this okay?
Yep.
90% increase in surgical safety checklist. This is coming out of Kenya. And so if we start tracking our data and then following it live time, it's really incredible. So you can mark out what your impact metrics will be and then show that this happens to be for an obstetric thing, but you can do the same thing for trauma. And you get inpatient impact metrics. But the problem is that we don't follow our data, and we need to start following our data. This kind of thing for the people on the call to follow the data is now becoming more and more easy. This is on a system called Power BI, and the teams that we're working with on the field, they're super excited about doing this because they see a difference for the patients. So I think there's a real important part of showing that impact of the training having on the patient impact. Thanks.
Thank you very much, Jeff.
While they're setting up, I wanted to say how I'm encouraged by this group. You know, I think that what you're seeing on this screen, is a group of all walks of life, different backgrounds, religions, races, nationalities, et cetera, and I think that especially during these incredibly tumultuous geopolitical times, as healthcare workers, we have an incredible privilege to unfortunately see some people's in their worst of times. And I think that it is incredibly powerful to see how healthcare workers can work beyond the strains of the geopolitical challenges that we're seeing, to work together. It doesn't matter what your background is, and to better serve our communities as a primary focus. And I think that that is incredibly positive and inspiring, and we should use that tool to foster collaboration, to foster partnerships, and hopefully that will transcend into other sectors in life. And I saw my yeah.
Then I want to say something quickly. First of all, I want to thank you and your team because you made a turning point in emergency and trauma care in Palestine. This is one. Second, one important indicator is the increased demand on the course from provider, from Ministry of Health, and from different institutions. Now we are receiving almost a weekly request to conduct the course. And in my opinion, this is an important indicator of that people see the impact of the course. Thank you.
Thank you very much. We are past the top of the hour, currently at 8:06. I thank everyone for taking the time. If there's a desire to keep going, I don't mind. It gets me out of going back to round, so I'm okay with that. Jamal, I turn it over to you.
Ready now?
Perfect. Go ahead.
So, how are you? Hi, everybody. So I think that I do something on the chat. I have my first question. So first of all, hi to everybody. I think that McGill University just support the Palestinian people in the situation, which is, I think that it's a very, very difficult situation. So these courses help us, first of all, even in pre-hospital, so they can manage the patients, they can transport the patient to the hospitals or to the notification hospital. They can find the services that they need. My question was in the chat that we have in the TDTR courses some skills, lectures, skills, and exercises, everything. So we have some skills that we should use it mainly pre-hospital because of our conflict situation. So sometimes when they transport the patient from somewhere, it may take, as Dr. Ma'moon said, a lot of time. So sometimes the patients may need to support his airway, advanced airway endotracheal tube. But some institutions like Red Christian did not allow the EMS or the paramedics to do this kind of skills, like intubation, chest tube insertion, etc., because of regulation, So how we can solve this problem? Because sometimes, if we delay to intubate the patient or to insert chest tube, you know that it increases the mortality rate, even the morbidity rate. So how we can solve this problem? How we can deal with these institutions, especially in pre-hospital services? This is my question. The second thing is that I want to thank all the McGill University and the doctors, mainly Dr. Dan, we was met him many times. for this facilitation, and Judur Institution, because they support us with this kind of training. So the main question is how, in the other side, I want to add something that the most important thing that we feel through this kind of courses, how we can do team performance or team dynamics, that how we can communicate and help and do all the components of the team performance. So this is a new skills that somebody
Thank you, Jamal. I think some a bit in the interest of time addressing your first question, and if people have that on the call, I think it's already a bit of how we've discussed. It's continuing education, recognizing the needs that are present, and then following data. One of the advantages of doing these courses, and as Jeff had brought up, you want to be able to log data, see how many participants are present, how we're training people, retention of data, and then it's with engagement from trauma leaders within your leadership at hospitals, but most importantly within government agencies in the Ministry of Health, to recognize, one, the epidemiologic need of trauma, and then secondly, demonstrate a commitment and success at training individuals, both in pre-hospital and in-hospital care, and then using that foundation as the argument to change certain regulations or limits that are placed on practitioners in order to address the needs of the patient. So all of this will be driven by data, and then having strong collaborations with ministries of health and government individuals in order to create advocacy to bring about increasing capacity of your workforce. To the second point, we'll just circle first to Dr. Konate, who's been waiting patiently, and then perhaps we'll address those two questions and move to concluding remarks, as we're already 11 minutes over the time. Prof. Konate, please go ahead.
Thank you very much, Jeremy. I would like to thank all the team of Global Surgery, especially Dan, Jeremy, Gabriela, all the team for their support. And it was very, very strong collaboration between us. Now we are going to 10 years of collaboration, which is very, very interesting. And many things have been built. We built a bridge between the North and the South, but also all the course we did, the TDTR helped a lot by building the capacity in our country. Now we have a very strong collaboration between the pre-hospital workers, like firefighters, and the SAMI is now leaded by a member of our team, which is very interesting for the future. And we would like to tell you that we are willing to collaborate for the future and also develop the future. And in any case, the collaboration is very, very helpful for everybody here. And thank you thank you very much.
Merci beaucoup, Prof. Konate. And I think with that, I'll turn things back over to my friend, partner, and colleague, Dan Deckelbaum, for some concluding remarks and perhaps to address briefly the importance of team dynamic training.
Thank you so much, Jeremy. And really, the key people responsible for the success of these programs are our partners all over the world, specifically some of those that you've heard today from Palestine, from Senegal, from Nepal, and of course Jeff at Global Surgery Foundation and your team. And I think that one of the things that the reason this is so successful is because there is such an amazing focus on training and education. And one of the things that I was thinking about during some of these discussions is how we've been able to actually do all of this together in a very, very cost efficient fashion. And if there's one thing that we should be focusing on is training and education, because it's one of the most cost-efficient interventions that has an incredible impact. And if you look at, Jamal is one of the lead nurses for the Palestinians, and the training of some of these life-saving skills, some of the surgeons, emergency paramedics, anesthesiologists involved around the world. It doesn't take much to put a tourniquet. It doesn't cost much, but it's a life-saving intervention. The same thing for a chest tube, same thing for basic airway management. And we've been able to prove that really over the years with barely, this budget is not even, it runs in the tens of thousands of dollars for an incredible impact. And the education of multidisciplinary teams in these life-saving techniques has been the key to the success. Jamal, you can, put a chest tube now on this table here. You don't need much resources. Same thing with a tourniquet, et cetera, et cetera. So, I think that the focus on multidisciplinary training is something that we actually can do better in Canada, in North America, and probably in Europe as well. And we also have a lot to learn from the work that you're doing in some of our partner nations, and how well you're doing it to improve care in our context as well. And I thank you for that realization, and I thank you for that privilege and incredible words that you've all said. And I look forward to not just continuing these programs, but growing them so that we can all have stronger impact on our communities and their safety.
Thank you very much, Dan.
Great to see everybody.
I think with that part onto it, it takes us to about a quarter of an hour over. I thank you everyone for taking the time out across multiple time zones throughout the globe to be here. We look forward to continuing our partnership with each one of the presenting groups here today and growing this program. And we look forward to having new members join on with CGS. We're always open to new and future collaborations. Again, a huge thank you to Gabriela Sanchez, who did a tremendous amount of work behind the scenes at putting this webinar together and making things run well. Like anything else in life, it's teams that will bring things forward. And we look forward to working with everyone again in the future. Thank you very much. Have a wonderful day, a wonderful evening. And thank you to all of our participants and to all of our presenters.